My name is Asma. I guess some of you know me. And I can see some familiar faces, but I could also see some new faces. So hands up if you came to London for this course. Okay, so welcome to London. We're very nice people, despite Brexit. We're a very welcoming nation. Okay, so just to get you going, so we really want this weekend to be interactive. We want people to ask questions, you want to contribute. If you've got some experience, we want you to actually share it with us. Some of you already have sent some cases, we've got some cases. Case discussion tend to be really popular, people like it, and I really would like you to tell me, okay, I'm gonna do this case, actually I don't agree with you, I would do it differently. Because we're here really to learn from each other. So just to get you going, it's 9 o'clock, it's a Saturday morning. So we're gonna start with some questions. And if you get all the answers correct, it's up to you whether you want to stay with us for the rest of the weekend or you might actually want to go and have fun in London. But some of you might have come across it because they were on the website. So in twin pregnancies with a short cervix, so defined as cervical length 15 millimeter, 22 weeks, which one of the following is evidence-based effective intervention to reduce the risk of spontaneous preterm birth prior to 32 weeks? You can shout. C. Everybody agreement? Yes? Certainly some people who sort of have a strong academic background, they might disagree, but the majority will agree with progesterone. Okay? Good. Which is the following is the most accurate marker to use for prediction of spontaneous preterm birth prior to 32 weeks in twin pregnancies? C. Okay, you're doing really well. So, cervical length. And certainly some of the other markers, either there's very little evidence on in twin pregnancy, or actually the one that's published does not necessarily show that it has better predictive accuracy than cervical length. And for us, who scan, costs you nothing. Yeah, so it's actually cheaper as well. During the follow-up of a woman with a monochorionic diamniotic twin pregnancy, which was complicated by TTTS, and had a laser surgery. So TTTS, laser, and you're following up this pregnancy afterward. What are the additional risks you should discuss and monitor for? C. Okay, so hands up for A. Only, okay. Recurrence of TTTS. Okay. Brain abnormalities. Heart abnormalities. All of the above. All of the above. Okay? So you'll be like measuring the pyometry, looking for the amniotic fluid, doing the Dopplers. But certainly, and particularly as they get bigger, it's more difficult to actually do the anomaly scan for all of them. It's just technically difficult. So the things that you really need to look for is the brain and the heart, because the abnormalities can become apparent after that. Don't just rely on the fact, oh, she had anomaly scan. Okay, so all of the above. During the follow-up of a woman with a monochorionic diamniotic twin pregnancy, which was complicated by TTTS and had laser, you diagnosed the intrauterine demise of the ex-donor 2 weeks after the laser treatment. Which of the following statement do you agree with? So should you just treat it as singleton? Well, because she had the laser and therefore the surviving twin will be okay. Or actually the risk of brain abnormalities in the surviving twin is not increased. That's a tricky one. What do you think? C, E, A. Majority, yeah? Shout louder, because you know we have you online streaming. So if you ask a question, you have to ask it in the mic. You have to shout louder, and we will be. They actually also interacting with us. They are to writing questions and comments if they like us or they don't like us. So so you need to shout louder. So E, yeah. So the pregnancy should not just be treated as singleton. It's still obviously at risk, and the brain abnormalities is still, the risk of brain abnormalities is still increased. Because sometimes we miss anastomosis, or sometimes the recanalization, yeah? In monochorionic diamniotic twin pregnancy is complicated by single intrauterine demise. One of the following statements is correct regarding the risks to the surviving co-twin. So is the risk of preterm delivery about 30%? The risk of the demise of the co-twin is less than 10%. Neurological abnormalities can occur in about a quarter of the surviving co-twin. All of the above statements are correct. None of the above statements is correct. C. Do you agree? Anybody has different opinion? We are in the democratic society, you know? Okay. So yes, you're right. The neurologic abnormalities in about a quarter, 20 to 25%. The risk of preterm delivery is much higher than that. Okay, so it's a long scenario. A woman with uncomplicated monochorionic diamniotic twin pregnancy, she comes at 30 weeks. She comes with complaining of reduced fetal movements. The ultrasound scan, to scan her, you diagnose that one of the babies have died. So single intrauterine fetal death. There's also polyhydramnios. And this baby had estimated fetal weight discordance of about 15%. The surviving twin, you do the Dopplers and have negative or absent endostolic flow in the umbilical artery, and the middle cerebral artery peak systolic velocity is 60 meters per second. The fetus has tachycardia and reduced movements. One of the following statements is correct. So pregnancy had complicated by TTTS, superimposed on selective fetal constriction. Urgent delivery should be planned after a course of steroids to avoid the risk of demise of the surviving co-twin. Should do urgent intrauterine blood transfusion. You should do urgent fetal brain MRI to look for brain abnormalities. None of the above statement is correct. Baby needs blood transfusion. Any other opinions? Okay, how do you know that the peak systolic velocity is above 1.5 mom? Approximately, if it's a double the gestational age. Yeah, so if it's a double, it's likely to be above 1.5. Okay, so this baby, so it's clearly that maybe had a TTTS, but single intrauterine demise, surviving twin have abnormal Dopplers and have anemia. Yeah. And therefore, the correct answer is urgent intrauterine fetal blood transfusion. And then in the talk on the single intrauterine demise, we will discuss about how do you determine whether actually this baby needs transfusion or not. Okay, one of the following statements is correct regarding the diagnosis of MCMA twin pregnancy. Single placental mass, absence of inter-twin membrane. There are two distinct arterial waveform patterns with different heart rate are seen within the same sample gate, the Doppler gate. All of the above or A and B are correct. Interesting, this is the easiest question of all the questions. What do you think? D. D, correct. The experts saying it's D. You're right. So all of the above are correct. In order to diagnose MCMA, and we will know from the lecture later that cord entanglement is almost universal. All monochorionic monoamniotic twins, they will have cord entanglement. And in fact, if you see cord entanglement, that actually almost says it's a monochorionic monoamniotic twin pregnancy. Okay, good? Fine.